Hello, everyone. Good afternoon, and welcome to the very first guest lecture from a wonderful anaesthetist, a dear friend, and a colleague, Dr. Ellen Kemp, who is the doyenne of anesthesia in Johannesburg, the finest anaesthetist and cardiac anesthesiologist perhaps that you will ever meet. And I'm so grateful to her for being willing to give us this talk on cardiac pressure volume loops. Dr. Kemp taught me everything there is to know about physiology and about anesthesia, especially cardiac anesthesia. And she will, in her own brilliant way, be speaking to us and explaining cardiac pressure volume loops. Guys, I hope you enjoy it. Please let me know what you think in the comments. Remember to like and subscribe. And don't forget, there are 2 live events with Dr. Tristan tomorrow. The first one with Dr. Radhika is called Is Pharmacology Difficult podcast. This is a wonderful podcast in India, and I will be appearing on Dr. Radhika's program. And then Dr. Kemp and I will be live tomorrow, Wednesday evening at 7:30 p.m. to do our first live guest chat on all things cardiac anesthesia. I hope you register, and I hope to see you guys there.
My name's Ellen. I've been a clinical anaesthetist for 38 out of my 43 years of clinical practice. And I have to confess that for quite a few of those years, I wasn't a fan of cardiac physiology. I used to open the textbook to the page and see all these awful graphs and loops, not really understanding what was going on, not seeing the clinical relevance to me, and cramming it and forgetting about it. Of course, I've had to eat my words since then, because I've come to realize that it's really important to be able to understand cardiac physiology, because we have so many patients that are hemodynamically unstable. And if you can at least understand what's going on, it's much easier to treat them. So instead of saying, oh no, the blood pressure's low, I'm giving adrenaline, it gives you many options. So without further ado, let's dive into pressure volume loops. I like to start by separating the pressures from the volumes. And everyone who knows me knows that this is my absolute favorite drawing. And it's a picture of the heart. And it shows that I've written there that the right atrial pressure is about 0 to 15 millimeters of mercury, with a mean of about 5 millimeters of mercury. The atria do contract, but they don't really contract well enough to cause a significant difference between systolic and diastolic pressures. The right ventricle, however, does. When the right ventricle contracts, the pressure reaches about 25 millimeters of mercury, and when it relaxes, the pressure falls to about 0 millimeters of mercury. People often get surprised when they realize how low the pressure goes in the ventricle, but of course it has to, because if the pressure in the right atrium is only 5, there's no way on earth it could ever fill if the pressures didn't drop really low. In the pulmonary artery, the systolic pressure is 25 millimeters of mercury. Well, I suppose it's getting its pressure from the right ventricle, so that explains it. But the diastolic pressure is 10 millimeters of mercury. And this is due in part to the presence of a pulmonary valve, which stops backflow, and runoff into the lungs. The mean is about 15 millimeters of mercury. On the left side, the pressure in the left atrium reflects the pressure in the pulmonary veins, and this is because the pulmonary veins have got no valves at all. So whatever pressure is there is the pressure in the left atrium, and that pressure is the same as the pulmonary artery mean pressure of about 15 millimeters of mercury. In the left ventricle, again, there's a distinct systolic and diastolic pressure. In a normal adult, the systolic pressure would be 120 millimeters of mercury, and again the diastolic pressure has to fall really low in order to allow the left atrium to fill, so it's 0. In the aorta, the systolic blood pressure has to be the same as in the left ventricle at the end of systole, because that's where it's getting its pressure from, 120 millimeters of mercury, and the diastolic pressure is 80 millimeters of mercury. This is in fact caused by the presence of the aortic valve and by runoff into the body. Of course, here's just a little summary of these pressures and a little bit about them. And these are the pressures again on the left side. When we talk about the volumes in the heart, there's a few very important concepts. So we talk about the concept of the cardiac output, which is the volume of blood pumped per minute. And obviously that's the same on the right side as it is on the left side. In other words, the same amount of blood goes to the lungs as goes to the body with each heartbeat. The other thing that you need to know is that there's quite a complex relationship between the cardiac output and the pressures in the heart and the great vessels. This relationship is not linear, and the pressures do not directly correlate with the volumes. In other words, a high pressure does not necessarily mean a high volume, and vice versa. Of course, we use pressure because it's easy to measure, whereas volumes are not. So the stroke volume is the amount of blood pumped per each heartbeat, and an average stroke volume for an adult is 70 mils. The cardiac output, of course, calculate by stroke volume times the heart rate. And here are just a few examples of cardiac output. A normal cardiac output in an average adult is 4 to 6 liters a minute. Women get a bit less. If you're an elite athlete, you can pump 35 liters a minute. Notice pregnancy requires quite a bit of increase in cardiac output by term, and neonates, infants and children have a considerably lower cardiac output. There are three things that affect cardiac output, as we know. The first of these is the preload, and that refers to the amount of blood entering the ventricle during diastole. It varies quite a lot from beat to beat, and influenced by many factors, including the dynamic and static pressures within the vein. It's quite a complicated concept. Peripheral vasoconstriction, vasodilation, the amount of blood in circulation, and other factors such as gravity and respiration. Contractility refers to the strength of cardiac muscle contraction, and we normally like to measure it using the ejection fraction, although in fact this wasn't originally the purpose of the ejection fraction. It was for the cardiologist to monitor treatment of left ventricular failure. And the ejection fraction refers to the percentage of blood that's ejected from the ventricle per beat. So therefore, it does not in itself indicate the stroke volume directly. Patients with a low ejection fraction can have a normal stroke volume, and patients with a high ejection fraction can actually have a low stroke volume. The normal ejection fraction in a male is 50%, and the normal ejection fraction in a female is 55%. So this means, considering volumes, that if your stroke volume is 70 mils, at the end of systole, there has to be 70 mils of blood still left in the ventricle. And at the end of diastole, there has to be 140 mils of blood in the ventricle. The third thing that affects the cardiac output is the so-called afterload, which refers to a complex entity called the systemic vascular resistance on the left side and the pulmonary vascular resistance on the right side. One of the interesting things about the PVR and the SVR is that if you notice, for the same amount of blood, the difference in pressures between the pulmonary artery and the aorta means that the systemic vascular resistance is much higher than the pulmonary vascular resistance. In fact, this is probably by a factor as much as 10, and that also explains why the left ventricle is so much stronger than the right ventricle, which doesn't normally pump against pressure. So let's now combine the two, and we'll get this awful graph. So how do we make a pressure volume loop? Well, we start off with two axes, and on the x-axis, by convention, we put the left ventricular pressure in millimeters of mercury. And you'll notice I've put in a few values there that are quite useful to us. 15 for the left atrial pressure, 80 for the diastolic blood pressure, and 120 for the systolic blood pressure. On the y-axis, we have got the left ventricular volume in mils, and here is 70 mils, and there is 140 mils. By convention, we usually start the pressure volume loop at the point where the mitral valve closes and contraction of the ventricle begins. So at that point, the volume in the ventricle will be 140 mils, and the pressure is about 15, maybe a bit more than that. The initial phase of contraction is called isovolumetric. In other words, the pressure in the ventricle goes up, but the volume of the ventricle does not change. It's a bit like squeezing a toothpaste tube with the lid on, isn't it? When the pressure gets high enough, the lid of the toothpaste flops open, the aortic valve opens, and that signals the end of isovolumetric contraction. And in a normal person, this would be at about 80 millimeters of mercury. From then on, the blood ejects into the aorta until the pressure reaches about 120 and diastole finishes. This is point 3 on my little mark here. At a pressure of 120, the aortic valve closes again. And here is our complete. And here is our complete.
So here is our complete graph, guys. As you see, number 1, the mitral valve closes and isovolumetric contraction begins. Number 2, the aortic valve opens. This is the end of isovolumetric contraction, and blood is ejected from the ventricle. At point 3, over here, the aortic valve closes and isovolumetric relaxation starts to take place. And at point 4, the mitral valve opens and the ventricle starts to fill.
There are a few other interesting things you can use this pressure volume loop for. And one of these is to draw a line through point 3, which is when the aortic valve closes and the maximal contraction is, down to the bottom. The slope of this line, called the end systolic elastance, is a surrogate of the contractility of the ventricle. And the steeper this line, the better the contraction. This is known as the end systolic pressure volume relation, or ESPVR. The ESPVR represents the maximal pressure developed by the left ventricle at any given volume. It is a measure of cardiac contractility. And the slope of this, also known as the elastance, indicates the strength of contraction. The other interesting line you can draw is this one at the bottom, which is called the end diastolic pressure volume relationship, or EDPVR. And this is a surrogate of diastolic relaxation. It refers to the maximum pressure in the ventricle at the end of diastole, and therefore gives an indication of the compliance of the ventricle. Notice that this is the exact opposite of the elastance of the ventricle as measured by the ESPVR. Another thing you can see on this is the stroke volume, which refers to the size of this pressure volume loop, we could also work out the left ventricular end diastolic volume and the left ventricular end systolic volume. And here is a slide, a more professional slide, of all these values that you can find on a stroke volume loop. And here is a slide showing what happens to the pressure volume loop when you change the preload. If you reduce the preload, you reduce the stroke volume without really affecting the contractility or the relaxation. And similarly, if you increase the preload, you increase the stroke volume without changing the contractility or the relaxation. And this, of course, is an example of the Starling effect. An example of what happens if you vasodilate a patient and reduce the afterload. Notice that the relaxation of the ventricle stays the same. The end systolic pressure reduces, but the stroke volume is often increased. In other words, even if the blood pressure is lower, cardiac output is in fact higher.
That is a very important concept to understand, guys. A low blood pressure does not mean always a low stroke volume and therefore a low cardiac output.
This is what happens to the pressure volume loops when there is heart failure. Notice that the line of ESPVR, which indicates contractility, is much less steep in cardiac failure. The maximum blood pressure is lower, and there's also a smaller pulse pressure difference between the systolic and diastolic blood pressure. Generally speaking, if you get a patient who's got a normal-ish systolic blood pressure, but an unusually high diastolic blood pressure, just be careful. They might have compensated heart failure, and they're just waiting for you to give them some propofol or to reduce their sympathetic outflow to give you an interesting time.
Critically important pearl of wisdom there from Dr. Kemp. I'll say it again. Just be careful of a patient who's got a relatively normal systolic blood pressure, but a very high diastolic blood pressure. They may be on the edge of compensated cardiac failure. Giving them propofol or big doses of volatile may cause that cardiac failure to become fully decompensated.
And this is a graph showing the effect of diastolic dysfunction on the pressure volume loops. Notice that if there is diastolic dysfunction, this line of the EDPVR changes and the pressure actually goes up. Diastolic dysfunction is itself a very big topic, but certainly one of the ways to diagnose it is on the pressure volume loop.
We will have a full lecture on cardiac failure when we do our cardiac physiology lectures.
There's still quite a lot to be said for pressure volume loops in various conditions, but I think we should stop there for today. Thank you very much for listening to me, and have a good night. Cheers.
Thank you so much to Dr. Kemp for that wonderful summary of pressure volume loops, as only she can. I'm going to be asking Dr. Kemp to extend her grace again to me, as she always has during my career, and I'll get her to do a few more physiology lectures in cardiacs for us. But that's it for now, guys. I hope you enjoyed this. Let me know what you think. Remember to like, share, and subscribe, and register for the events on YouTube, TikTok, Facebook, and everywhere else. Tomorrow morning, or afternoon, should I say, at 5 p.m. our time, will be Dr. Tristan appearing with Dr. Radhika on the Is Pharmacology Difficult podcast. And then Dr. Ellen Kemp will be appearing with me as our first live guest episode, where we do a cardiac anesthesia Ask Me Anything. Have a great evening.